Me too, Mr. Moore, please.
Maria.
Hello.
Macy. Jenna.
Oh.
Afternoon, Jordan.
Hey, Professor Moore.
Hey, Jasmine.
Hello.
Okay, where's Mitchell? We're ready to go. All right, let's get started. I was going through trying to get exams sort of in line today, and I kept looking for questions to put on the exam, and I wanted to be sure and remind you, because they're not listed, of some words that you need to be sure to keep up with. So let's do that first. The tissues that we're going to be involved with on this lab exam: stratified squamous tissue, simple columnar tissue, pseudostratified. Now you remember where those are. It's been a while since AP1. If you don't remember these kinds of tissues, go back and review them a little bit, or ask questions about them later on, and let's discuss them a little bit. But there are some other tissue names that are more obvious, and they're in the list of things like mucosa, submucosa, the cartilage that's beneath the respiratory tissue. Be sure you understand endocrine cells as opposed to exocrine tissues. Be sure to keep those terms in your mind. And I just sort of canceled the information on those two digestive ones that are, they don't have very much on them anyway. I do want you to remember there were enzymes on one of those pages. I do want you to remember enzymes, especially amylase, because that's the one we deal with a lot in this course. So be sure you remember amylase. Remember, amylase breaks down starches. So those were just some terms that I came up with. And by the way, another one is the diaphragm muscle. Now the diaphragm is on one of our drawings, but it's not listed on our paper. So I was just picking out things that are not actually listed on the paper that are in the PowerPoints. And I want to revise this for the next set of students so that we'll be able to look at this sheet. I want everything that on the exam to be on the sheet. That's one of the things I think about expectations that we ought to have as teachers, is allow students to know what's going to be there and not try to trick you by asking a bunch of stuff that's maybe not on there. All right, I think I'll go ahead and start and go over the 3 PowerPoints. Just a moment, let me see if someone's out of class trying to get me. Yep, that was Mitchell. Said he's not going to be here, so we're not going to wait on him if he's not going to be here. All right, here we go. Lymphatic first. Slide number 2. We've seen this a dozen times, so be sure we have the capillary, blind capillary, and understand what lymph is. Lymph is the fluid that is in the lymphatic system. Slide 3, this is slide 3. I guess most of this has to do with secondary lymphatic tissue. But other than just identifying these locations, this is much better because it shows the primary versus the secondary. And so I really think that this one covers things better than this one does, because this one is not very specific and this one is. So certainly slide 4 is going to be in there, and we need to know what the primary tissue is, what the secondary tissue is, and know examples of all of it. Five and 6 have to do with the lymphatic ducts, and here it talks about them, but here it identifies them. So certainly be able to identify this as the right lymphatic duct and the thoracic duct here. Know where they go. Be sure to know the part of body that's drained. It really, I'm not sure that it says that anywhere here, but be sure to know the drainage area of the body for each one of these duct systems. Remember, the right is just this upper right side, and the left, or the thoracic, is everything else of the body. Maybe that's on this. Yeah, it's on this slide is where that is. Slide number 9. So it's a good picture to use, because there's a lot of things that you get, and you can even get the lymphatic ducts here if we needed to, but it does bring out the nodes. There are 3 node sets here: cervical, axillary, and inguinal. Then it has the thoracic duct and the right lymphatic duct. So that picture has pretty much everything that we need to know about it. Ten talks about the terms, but let's identify the terms here. This outer area is the cortex, just like it is in the kidney. This inner area is the medulla, just like it is in the kidney. And then we have the Lymphoid follicles. Each one of these has what's known as a lymphoid follicle. Toward the center of this is the germinal center. So these are the areas of the lymph node that we need to know. Also, the outside, the capsule. So this is in number 10, 11, and 14. So 10 is the list of them. 11 shows them in this drawing, and 14, I don't really see anything on 14 that excites me as far as, we've got other places where we can see a germinal center better in the iris patches. So we'll probably save that. 17 is the spleen. This is an interesting look at the spleen. It sort of shows, it sets up the next picture. This is not one of them that we have in our list, but the spleen is just a great big old sponge. Has a covering around it, and then it has red pulp and white pulp. And the red pulp is basically the storage area for red cells, and the white pulp is storage area for white cells, leukocytes. It's not much more fancy than that. Number 19, when we look at malt, we've talked about this enough. I think everybody can tell what all is in malt. Just be sure that you understand tonsils and appendix is also malt. Peyer's patches is easily part of it because we think about the epithelial area. And when I get to 22 and 23, these are the ones that I want to look at. Be sure you look at this one. This is in the small intestine. This is a villus. So these are Peyer patches here. This is it says in the ileum, so it's the lower part of the small intestine. These are germinal centers here in the middle of these Peyer's patches. So these are places where secondary reactions are going to occur.
Hey, Professor Moore.
Yep.
I had a quick question. I was pulling up the new slide when you started off. So I got slide 2 and then slide 5 and 6. And then you mentioned just the lymphoid organs and tissues, right? Is that the ones in between there?
Yes.
Okay.
Does that new set have everything in it that I put up on Blackboard?
Yeah, I think so.
Okay, good. I never had trouble, but I had just an hour ago, I had a student from the other class ask for the digestive PowerPoint, just to email it to her because she couldn't get some of that. Is that Blackboard that's causing that trouble? I don't really understand where we're having her.
It took me a minute to find it. So you put it in like the updated slides, you put it in like a different section under course materials. So that threw me off. So I was like trying to dig through it and find it. It looks good.
I think I moved it to the very front though, of course materials, didn't I?
No, it's below the ones that you did last time. Like the old ones, it's below them.
I know I moved it because whenever you put something on, it goes to the very bottom. And so I know I moved it, but I couldn't remember exactly where I stuck it. I tried to see it, fix it where it'd be visible. Okay, respiratory. I've said on this one, all parts, but here is the only place where diaphragm is in this whole thing, and diaphragm has got to be a part of this lab. I never have fixed my set over here. Just a moment. So this drawing will probably be on there half a dozen times. You've got lots of parts that are here. You can see the lobes of the lung here. You can see the trachea, the bronchi. You can see carina. I'm not concerned about primary bronchus and secondary as they branch. The first branch is primary and secondary. I'm not concerned about those. But everything else on here is pretty straightforward. Probably would not use the nasal passage here. I'd use the drawing that has a close-up of it. So I think maybe just the lung set here is what's big about this drawing. So definitely use this drawing for palate, probably for the other two tonsils even. The conchi for sure. I won't put sinuses on this. Those are AP1 stuff. Can't put glottis and epiglottis in this one. Doesn't show up. So that doesn't show anything. That. So it's number 7 is the next one. So we can see all 3 sets of tonsils here. This is probably the one I'd use rather than the other, if I can get it free from all of the writing. So under slide 7, 3 types of tonsils: the hard and soft palate, the hyoid bone, and the epiglottis. So all of those show up well here. There's not a whole lot I'm going to ask you on this. It does show the hyoid bone very well here. But after that, I don't know of anything unless it's the cartilage in the trachea that I would use here, other than knowing that this is the larynx. So certainly know that this is larynx. 12, and certainly can use these slides. Glottis, vocal cords, false vocal cords. I wouldn't ask you the epiglottis here because it just doesn't show up that well. These 2 drawings would certainly be useful. I have a drawing that is like this, that's clean, doesn't have all these lines all over it. You need to know those tissues: the pseudostratified epithelium, as well as the submucosa of the cartilage. What this is trying to show you is simply the relationship of the trachea and the esophagus, not epiglottis, esophagus. And we saw that in the video. I don't think I'll address it here. This one shows the layers up quite well. It's probably subject to being on the exam. It doesn't show the epithelium type. I don't think you could tell that that's pseudostratified, but you could tell it's epithelium. So in a drawing like this, epithelium, submucosa, cartilage, certainly we could use this for that. Lobes of the lung, certainly know these. This is the drawing that shows primary and secondary branches of the bronchi. I don't really care about that. '23. 23 up here in this diagram shows you the layers of the lung tissue, but I have another drawing that's probably better. So I probably won't use this drawing. And the only thing I would want this for is for these layers to show the parietal and visceral pleura. You do need to know those. And then this histological slide here, that one's not very good. Maybe one of these others somewhere that shows. Remember that we talked about these being passageways. So wherever it's clear, that means it's air. So there's no tissue. So those have to be bronchioles. So that you see one here, but you don't see this one where it goes. So this is sort of a directional change. This one's either going toward you or away from you. This one's going side view. And then the little tiny holes, if you can find a nice circular one, would be alveoli. So here, the arrows do a good job here. Okay, end of respiratory. The digestive one. Surely we know all these organs by now. Here shows us part of the tonsils again. Once again, we don't get the adenoids in there. And I haven't mentioned this one in a while, but we have the frenulum here and a frenulum here. I think both of those are in here. No, it's just the linguinal frenulum, so the one that holds the tongue. See, there's a connective tissue covering that holds the lip to the gum and the tongue down to the base of the gum area here. So this is the only one that's on the exam though. Five and six. The salivary glands. This is where the amylase is. I knew it was in the slide somewhere, but I couldn't remember where it was. So this is why we're responsible for amylase. The three salivary glands are in this picture. This is number 6. These are fairly easy to remember because they're all located by a place that's something you already know, or I think you still would have it from AP1. Lingual and mandible, and then the parotid area. We've studied this from lecture. You still need to have a good feeling about these layers, sort of what each layer is for, anything that goes on with it. Mucosa, of course, is absorption areas. Submucosa, this is basically support tissue. Muscularis, it's a smooth muscle, peristalsis, and so forth. Connective tissue, outer covering, all of that's full game on this slide. The esophagus, this layer, I'm not sure that there's anything on here that tells you this is the esophagus if it's not labeled. Notice that you have the identifying cross section here of where that is. So I'm not sure this picture is necessarily going to be something that we would look at, but as we talk about these layers, certainly when we get to something like this or this, we need to be able to recognize the layers of muscle, the layers of submucosa, and then the layer of the epithelium itself. I am not going to ask you this muscle layer here. This is that little thin layer of muscle. Just be sure you know it's there, because this tissue out here is not submucosa yet. This is the submucosa after this little layer of muscle. So be sure you can identify the submucosa in this kind of diagram. And then this is circularis. This is the muscle that we want to label here. So this is where I'm asking you to be sure that you can recognize stratified squamous tissue there. (13). So we have all of the parts to the stomach. Just be able to recognize all of them, as well as the pyloric sphincter and the rugae. So we get to number 14, we get into the stomach, and actually 14 is not in our list, but 15 is. It's the blow up of that area. So this is the lining, similar to the picture before: mucosa, submucosa, muscularis. This is the little layer of muscle, the little thin one right here that we've talked about that we're not going to worry about. So any labeling of this layer beneath the mucosa is going to be submucosa and not muscularis. We'll only deal with the thick muscle layer that's down below. We should be able to recognize that this is stomach tissue. We should be able to recognize that this little undulation here is actually the gastric pits, and it's not villi like the small intestine has. And if we get a large enough blow up like this one, we should be able to see columnar, simple columnar cells and these gastric pits. Okay, so stomach lining as opposed to the lining of the small intestine. So be able to recognize that this is the lining of the small intestine and not the stomach. I think that one's easy. It's recognizing that the stomach is not the small intestine is probably the more difficult one. We have to see that this is not really villi here. This is just stomach tissue that's a little bit unlevel, but it's still not like the villi in the small intestine. And remember that this is the lining of the intestine itself that we're not going to deal with either. We're only going to be dealing with the villi that's on those folds in the small intestine. So in any of these, we should be able to see villi, and we can see where crypts are. These spatial areas are where the crypts are going to be. And I will pick out a good diagram. This one shows you the cells. You're responsible for the cell types here. You're not responsible for microvilli in this picture. Certainly we can see crypts here. We can see villi here. You can see the simple columnar tissue here. Here you can see the crypts and the villi. Do you guys remember or recognize that this is smooth muscle tissue? See the elongated cell, elongated nuclei. Remember this from AP1? This is a famous slide. It's in almost all textbooks. Whoever made this probably made a lot of money off of that one little picture. We need to know this component, that it's an acinus. Know that these are exocrine ducts here, passageways. Be able to recognize this tissue. Now, these are tubules. They're not layers, or they're not acini. But here, when you see little columns here, those are acini. These are passageways. So that's carrying the fluid away from the acini. But when you see these little circular areas here, those are acini. So those are little compartments like this. You're seeing these little circular compartments whenever you see these structures that do not have a duct in between them. So this is not an acini. This is a duct. These are acini here. All these little circular areas. Out here, some good ones down here. And then this component is the islet of Langerhans. So this is considered to be an islet cell. This is endocrine. Secrete material directly into the bloodstream. This is exocrine. Uses tubes to secrete to other locations. And in fact, see, all of this is going into the small intestine by these ducts. The secretions here go directly into the blood. And remember, glucagon and insulin are the two primary secretions of these cells. Parts to the small intestine. The whole list of them here. There's way too many names in this picture. But certainly have plenty of opportunities to name these. But what's listed there is what we'll use, and I think we've gone over those in lecture. So cecum, ascending, transverse, descending, sigmoid, rectum, anus. ileocecal sphincter, appendix. I really can't see anything else on here. This one, internal muscle. So this is the involuntary smooth muscle of the anal sphincter. This is the voluntary skeletal muscle of the anal sphincter. These would be circular muscles that go around the anus. These are muscles that line the outside of that anal cavity. '40 through 42, just being able to recognize that this is gastric lining in a drawing. These are gastric pits. This is the muscle tissue, and probably we have a blow up somewhere, but submucosa is going to be right down here in this area. So be sure you can recognize mucosa and this is, of course, is mucosa, but recognize submucosa in the gastric in a picture, and recognize, let's see, is there a better, yeah, there's a better diagram here. Recognize the mucosal area now look, there's a little bit of difference here. Notice when the crypt goes down in here, that extends the mucosal area a little bit deeper into the area. So when you're talking about mucosal area, the crypts cause this to be a little bit wider in the small intestine than it is in the stomach. So the mucosa is a little bit, I think it's, where is it? It's a little bit harder to see. Well, it doesn't show it in any of our diagrams, so I guess it's not going to be on the exam. Here's an interesting diagram. This is the closest we see of any of these columnar cells. You see the nuclei very well here. So this is a nice villus with the columnar cells very obvious in this diagram. These are microvilli. They would be on the cell membrane, remember that. So I could ask a question on this like, what is in this view? And you would say a cell membrane. That's microvilli of a cell membrane. All right, that's all of my questions or answers, I guess. It's all of the answers to the questions that I'm going to ask on the exam. What do we need before I close this out? Any questions on this PowerPoint?
I got some. Can we just go over the stratified, squamous, pseudostratified, and all those, and where they go again?
Yes.
Because I get those mixed up, and I've struggled with that a little bit.
Yeah, it's because your AP1 teacher didn't do a good job with you.
Yeah, I know, that's what I've been saying.
Can you tell that's stratified squamous? Not really?
Yeah, I need a refresher on being able to like look at it.
Just a moment. Let me do something here. Just give me a second. I'll get there. Remember this? Looks more like this right here, what we're seeing. That's stratified squamous tissue. That's what's in the esophagus. What we're looking at in the tissue that's in the stomach and small intestine, we see something more like this. That's the simple cuboidal.
The columnar, right?
I'm sorry, columnar, simple columnar. Now, the pseudostratified, maybe this one. This one's if we had a really good close-up, it would look more like this. Now, pseudostratified is always bronchial. So it's going to be in the respiratory system. So in the digestive system, it's always going to be simple. In the respiratory system, it's always going to be the pseudo-stratified, which is really simple, but remember, it's this unique kind of simple, so we call it pseudo-stratified. And then in the esophagus, it's going to be the stratified squamous.
Okay, so the strata, if I remember from last class, you said stratified squamous was only in the esophagus.
Yes.
Okay.
And it shouldn't even be there because, well, when I say it shouldn't, digestive system should have a better protective lining than stratified squamous, because stratified squamous, even though it's thick, it doesn't have any protective secretions to speak of, where the columnar does, because it's got the goblet cells and it produces the mucus. So let's get back to that digestive system PowerPoint. So this just doesn't look like any of the other linings. Look at sort of the submucosal level here. Now look at the thickness. Look how many cell layers there are to this stratified tissue. And then let's go down and look at the see this tissue layer looks that now these are not the same size pictures. This looks as big as that stratified, but if you look at it compared to there's one, the thickness of the tissue. See, these are very thin layers compared to the thickness of the submucosa down here. So see, those are the little thin lines of tissue there. Compare that now, go back to this drawing and look at the thickness of this layer compared to the tissues down here. This is huge, thick for epithelium, and therefore that's the stratified that's got so many layers there of those squamous cells. They just have a different look too. You don't see that lineup of nuclei in them. I mean, all of those little dots are nuclei, but they look like salt and pepper rather than the classic lineup. Look at the lineup of the columnar cells, how those long nuclei make a row. The one that's hard to pick out of this is the pseudostratified, and we've got to go to that different PowerPoint, go to the respiratory one to find that pseudostratified tissue. Oh, that's the wrong one. I've got one more thing to do, don't let me forget. here is the one that we're looking at. And this tissue layer has a black lines and it's distracting, but it's really, this looks more columnar. So confusing this one with the one in the stomach or in the small intestine is more likely than confusing the stratified squamous with the columnar, because this is basically a columnar tissue. It's just got all of these levels of nuclei in it, and you have to see this one up pretty close to tell the difference that makes it pseudostratified. But let me tell you the key. The key to finding the pseudostratified tissue is this tissue right here. See, in the respiratory system, you're going to have cartilage beneath these tissues. And in the digestive system, you're not going to have cartilage cells anywhere around those digestive tissues. So the key to finding pseudostratified is to find the cartilage. The submucosa is pretty much alike. But see, in the digestive system, whether it's in the stomach, in the esophagus, in the small intestine or large intestine, underneath the submucosa, you're going to have muscularis. You see no muscularis here. So there's the key to getting that correct.
Thank you. That was very helpful. I had another question. On the respiratory system, you skipped over physiology. Was that intentional?
No, that's what I said. I've got to go back and get that. I picked up that PowerPoint here. I mean, and remember that there was only these 2 slides that we were going to have on it. And it was this definition slide, I believe. Let me see. Number 9. Yep, that's where I am. So knowing tidal volume, inspiratory reserve, expiratory reserve, and residual. So basically, residual is what stays in your lungs at all time, and you can't blow that out. Tidal comes in and out. The tide comes in, the tide goes out. Okay, so that's what you're breathing in and out. Under normal circumstances, that's going to be a small amount. It says it's only about a half a liter. The amount that you can force yourself to breathe in is about twice as much as the amount you can force yourself to breathe out. So this is inspiratory reserve. You take a deep breath. That's quite a bit of volume that you can take in. This is just being from relaxed and then blowing out. You can't exhaust nearly as much out of your lungs as you can breathe in. So these 4 conditions are the only ones that I was going to deal with. Here's a sort of a chart that shows it. This is a amount that you deal with all the time, comes in and out. This is how much you could take in. This is how much you could blow out. So your residual volume is what's left after you exhale all that you can exhale. And I'm not too concerned about these volumes. The only thing that you might really, if you want to remember something, remember that inspiratory is much greater than expiratory as far as your capability. I don't see dealing with these numbers so much because they're going to change with every individual. And in fact, there's a gender change anyway that it addresses on this PowerPoint. And the gender difference is of like 25 to 30% difference. So I don't see any point in learning these numbers because they're going to change. maybe it would be valuable to remember that your tidal volume is only about a half a liter. But I'm not going to ask you that question. I'm thinking about how is this going to benefit you further down the line. And to me, the idea of I can breathe in a whole lot more than I can exhaust out is something that might benefit you down the line somewhere if you were working with someone in respiration. But I don't know knowing that volume is going to do anything for you. I'm of the opinion that you don't need to remember anything that you don't need to use, because your brain has only got so much room to put stuff in it. Don't fill it up with trivia. All right, anything else on the lab? I just feel like you guys ought to do well in the lab. It's just knowing the stuff, because I'm not going to throw any curves at you. I just want to know that you know it.
Professor, on PowerPoint 12, on the list of things, it didn't list number 45 and 46, but we do need to know those.
On 12?
Yes, we're on the digestive, PowerPoint 12, but it was number 45 and 46.
Let me look and see what those are. I guess this was this in our lecture? I guess this picture was in the lecture, right? This is just a villus. Yeah, I've got this picture that's clean, and yeah, it'll show up. This picture will show up somewhere. I have microvilli on here somewhere, right?
I believe it's on the lecture.
Well, I'm thinking that this picture, I may be getting confused that it was on the lecture, but let me see if we have microvilli anywhere on this list of what we have to know. I don't see it. I think I left it off because we were doing it in the lecture. So yes, thank you. Villi are there, but no microvilli. So this one won't be there, but this one will. Anything else?
Can we, since it's been a while, can we go over lymph and the drainage areas or what you want us to know?
Sure.
I know it's simple, but it's been like a month since we learned it initially.
Well, let me look at the sheet. I don't know that. Yeah, distribution areas. Okay, let me find it. I must have closed it out. It's not in my group. Let me go back and pick it out of my files. All right, is that showing up? Yeah, it is. Drainage areas were here. So this area in green goes into the right side. So right lymphatic duct into right subclavian. This is the side that goes into the left subclavian by way of the thoracic duct.
Mr. I have a question on the blind capillaries. Those are like the beginning of a lymphatic or of a capillary, and they absorb extra fluid?
Yes. I know that on our exam, we had them leaking. Many of us had them leaking fluid. I don't know if it's this class or the other one. But I had, and I hope it's not something I said. I could have said something backwards like I frequently do and led a bunch of people astray, but no one accused me of anything, so I wasn't about to confess. So yes, this is for absorption. Yes, ma'am?
Can you show me the Adventia, PowerPoint 16 through 19 in respiratory?
Adventia is just sort of in some areas where you don't have like covering around a lumen like an intestine or something, and you don't have the serosa. Adventitia is just a name for a similar kind of covering on the outside area of something. And I don't really even intend to use it. It's just an outer covering. I saw it a while ago and I thought about saying something about it, and then something else messed up. Anything else on this one?
So for a question on the drainage, would it be okay to be like, okay, the thoracic duct drains the upper left or the upper left and the bottom and just
Yep.
keep it like that? Or do I need to like, okay.
No, general, very general. It's probably easier to describe the right-hand side than it is the left without, making a whole paragraph. And I'm not looking for that.
Yeah, you're one of the you're a different professor. Like I've had some have some I don't know, I don't even know the word for it, I'm drawing a blank on it, but they want it like verbatim.
I know. But to me, the generality is something you're going to remember longer.
Right, which is, I appreciate it. It's a hard adjustment,
Yep, I know. Been there and done that. I'd like to sometime tell you about my experiences in biochemistry at about 65 years old. I was set in my ways, and that 30-something instructor was set in his ways already. Actually, it's probably about 45. And so I didn't argue with him, but I said a lot of things under my breath, like you guys do all the time. Gabrielle is guilty, I can tell. Ready to go to lecture? I can't even find it on here. There it is.
I have another question, not regarding this before I forget though.
Okay.
The lecture exam 3 is still on April 6th, or
Yeah,
did
I
that?
don't, since we're gonna finish it tonight, I don't want to move it because I don't want to mess up the last test cycle because it's the one that probably is the most important for what you take out of here. And I'm just trying to look at it when it starts. Yeah. Yeah, because we're in good shape because tonight we'll finish, we just have a little bit to do with lecture. And we'll pick up the review on it next, when is that? Next Tuesday, we'll pick up the lecture review. And then Thursday have the lecture exam.
So the lecture exam is April 8th.
Correct.
Our
And
lab
then-
exam's this Thursday though, correct?
Say that again.
Our lab exam is this Thursday though?
Yes, it's next time.
Not an Easter gift, we do have to take it? I
It's
tried.
an Easter hunt. We're going to search for answers.
Ugh.
Hey, you're talking about someone that when they're growing up hunted Easter eggs for about 6 months out of the year. We would take rocks and wrap them in tinfoil and keep our Easter baskets forever and ever. So I understand Easter. All right. Let's just pick up on number 15 and see if we can find some pictures that support the idea. Oh, there's something I didn't cover the other night in kidney that I'd like to. When we were talking about some of it, we looked at a different picture on this, but notice the two kidneys here. Y'all ever realize this? That your right kidney is about 2 inches, maybe 3 inches lower than your left kidney. Just an interesting bit of anatomy. Urinary bladder. The urinary bladder, notice that how the ureters come in at the bottom. Two ureters come in, and this bottom makes a little triangle. These two urethral openings with the urethral opening make a little triangle base. That's called the trigon. And what this means is the bladder empties and flops down. And then when it fills up, it rises up, it elevates. So the bladder sort of fills in a different way you'd think about it. It doesn't fill up from the top. It's not like filling up a water jug or something. So it fills up from the bottom and inflates upward as it gets fluid in it. The bladder is a muscular sac, very, very tough, smooth muscle sac. It's not like the frog bladder. The frog bladder, if y'all dissected frogs, it was more of like a little, just a connective tissue sac, very thin. It was easy to rupture, but this is not. This is pretty tough. Now, some of you people in the audience will understand this, but when you get a little infant on the inside and about this position right here, and it starts pressing down on this bladder, the fact that the bladder tries to inflate upwards and you've got a little buttocks here that's probably in the way, it makes it where this thing doesn't have a very big capacity. And that's why pregnant women have to go to the bathroom so often. It's because that the little small bladder, that can hold up to a liter. A very full bladder can hold up to a liter, but not a female bladder, especially a pregnant female. That bladder holds about 200 milliliters, about it. So interesting little point of connection there. Okay, so the urethra drains it. You remember us talking about the urethra having two sphincters like the anus does? It does. It has one right up here at the opening of the urethra, excuse me. And then there's one down here in this muscle tissue, a little bit further down the urethra. This will be shown in lab, but it's in the exam 3 of lab, so I'm probably going to save it until then. But the urethra also has a dual sphincter system. It's just not arranged the same as it is in the anus. Micturition. Micturition is the correct terminology for urination. But in the medical profession, I have noticed, just observation, that there is a new vocabulary word that's in the scientific literature, evidently, because every time I get around a nurse and they're talking to their patient, I've never heard the word urinate. I've never heard the word micturate. They just always say, you need to pee. So I think this is the new vocabulary. This is the medical terminology for micturition now. It's PEA. That's the new word for it. Moving on to the testes. The testes are the male reproductive organ. The testes produce androgens. Androgens are the male hormones. Testosterone is the most common one. There is another version of testosterone called DHT. It's called, or its name is dihydroxytestosterone. It's just a version of testosterone. Both of those come into play as androgens. They're produced by Leydig cells. Leydig cells secrete the androgens. When you look at the testes themselves, they have these little convoluted tubules inside them called seminiferous tubules. Seminiferous tubules produce the sperm cells. The sperm cells move out this long tubule that comes together and goes through the sperm card, and it's called the vas deferens. Vas deferens carry the sperm up to the urethra where they're discharged through the penis. Right, see this term Wolffian ducts? In a concept, we're going to talk about the embryologic tissues that create the reproductive systems in both male and female. Wolffian ducts, and if you'll glance down under number 19, the last thing, Mullerian ducts, those are two embryological tissues that in lower animals like reptiles and amphibians create urinary systems. So these kinds of ducts embryologically become something else in humans. This is quite common. If you ever study embryology, systems that in lower animals do one thing will be converted to do different things in humans. It's sort of like the gill slits in sharks wind up being part of our ear system. So whenever you look at embryological tissues, the Wolffian ducts, these are embryological tissues that become the male reproductive system. We'll deal with this again in a concept. Now, one more thing that we need to look at in the male system is the idea of how the testes are arranged in the body. I think we all realize that they're not internal. They're exterior to the body cavity. How did they get there? Well, we know that in the fetus, at some point, I've forgotten really in gestation how far along it is, but at some point about probably 6 months or 5 months or something of gestation, the testicles descend and they drop to the outside and down into the scrotum. How do they get there? Well, there is a little passageway through the body cavity. That is called the inguinal canal. So in number 17, the inguinal canal is that passageway from the inside body cavity to the outside to descend down into the scrotum. That's the passageway for those testes. Now, think about that those testes are still living outside of the body, so they've got to have a connection. They've got to have a blood supply, they have a nerve supply. So they're still connected to the inside. And so that inguinal canal stays there, stays open. And many times men will have a hernia at that little opening. So that is called the inguinal hernia, whenever that stretches out and allows some of the organs from inside the body to sort of push out that opening, that herniated place. And many times people will have their colon will push through a herniated opening, and if it squeezes down on that colon enough, it can kill it. It can actually cut off the blood supply to it, and you can have some necrosis set in on the colon during a hernia. So even though hernias are not very difficult to fix, you do need to attend to them. So when we look at the inguinal canal, that's the place where the testes descend. And men frequently have inguinal hernias at that weakness in the abdominal wall. Another component that gives men a lot of trouble is this prostate gland that surrounds the urethra. The prostate is a donut-shaped gland, so it's got a hole in it that surrounds the urethra. And that prostate gland, of course, the role of the prostate is to produce semen. So some of the seminal products are produced by the prostate gland. But here, the difficulty comes when cells begin to encroach upon the urethra. Now that is called benign prostate hyperplasia. The initials for it are BPH. So BPH is the growth of cells on the inside of that little ring, and it begins to put pressure on the urethra and inhibit urine flow. Now, the same thing can happen with prostate cancer. Prostate cancer causes an increase in the number of cells, and that also can put pressure on the urethra and cut down the flow during urination. The difference is whether the cells are metastatic or not, or they're cancerous. So in BPH, This is a non-cancerous condition. Prostate cancer is when the cells have become cancerous. Prostate cancer is a slow-growing cancer, but it is also very, very common. I've heard it said many times that if a man lives long enough, he'll have prostate cancer. Now, I don't know how long you have to live for some people, but some people get it at 50, some people get it in their 60s, 70s, and some people get it in their 80s. So I presume it's fairly correct that if you live long enough, you will have prostate cancer. The PSA is a test for prostate cancer. PSA stands for, you need to know this, prostate specific antigen. Prostate specific antigen is a normal protein produced by the prostate gland. So when you check your PSA, if the levels are normal, let's say probably your prostate is normal. But if your PSA is elevated, that probably indicates you have way too many cells. And anytime your body, a gland in your body has too many cells, you suspect cancer. You suspect that it's a tumor. So the PSA is an indicator of prostate cancer. PSA doesn't mean you have cancer, but PSA is an indicator. You certainly want to, if you have a high PSA count, you certainly want to be checked for prostate cancer. Now, women must know about prostate cancer. All of you must be very well versed. If you have a man in your life, they're not going to take care of it. And you have to be responsible for helping them along. It's like finding the butter in the refrigerator. You have to help them out. So what you have to do is get them the appointment to the doctor, and don't tell them what it is. Tell them you're going fishing or something, Katie. And then you take them to the doctor, because the exam itself is not really a whole lot of fun, but it is very important that that exam get done. So I don't know, is this one, Jordan, that you've experienced yet, or are you still holding out?
The prostate exam?
Yeah,
I haven't had one of those yet.
well, you need to soon.
Don't they
Because
typically check them in the military?
I'm sure you have to do a
Right.
prostate check in the
Oh.
military.
Is that just when they feel?
Yes,
No. Oh,
well,
no,
well,
you're talking about churn and cough. No, that's where they
No, not turn and
two
cough.
finger feel. Yeah. I've had
No,
two.
yeah, I got a prostate exam for a training program.
Sorry, I didn't. Well, explaining it, my bad. Well, I've
Well,
had to witness. I've had to be in the room. That's why. Yeah. Okay.
well, the prostate exam, for those of you who don't know, they go through the anus. They feel the prostate through the small intestine wall, so it's right there next to it. And it's quite humiliating for any big old man to have it done. But this is why I'm telling you, women, you have to be responsible for getting your significant other into the doctor to do the prostate exam. Once you get them in there and get the door locked, then they probably can't get away very well. But you do need to get the door locked.
So pretty much make a date for a colonoscopy and a prostate exam.
That would be it. Yes, that would get everything covered.
Yeah, I think I've had 3 or 4 prostate exams since I've been in the military.
Well, Chase is not saying anything. He's hiding back there, so I don't know what's going on.
No, I had one when I had a surgery. I had a stricture, and they did one prior to the surgery.
Okay. I don't know how many I've had. I do have BPH. I don't have prostate cancer, but I have enlargement. And my proctologist, he has fun checking it out.
Is there a certain age when you should start getting tested for?
19. I say 19 because, no, probably 40 is really when you should, because that's when BPH usually sets in, is about age 40. You start getting diminished urination flow. But that's the thing about it. If guys would understand that if you start having difficulty urinating, there's got to be a reason, and many of them don't. I'll tell you this, a personal thing. My best friend in college, he was the best man at my wedding. He's a year and a half or so older than me. And last month, 6 months ago, he was diagnosed with stage 4 prostate cancer. He was a physics teacher for like 50 years in high school. A very intelligent kind of guy. And I cannot figure how in the world that he got through to stage 4 prostate cancer without knowing something and without being checked. And evidently he wasn't. I haven't visited personally with him in 10 years probably, but I know his son very well and see him much more often. So he keeps me sort of updated. But if you ever wanted to just pick up the phone and scream at somebody, that's what I wanted to do. But of course, when somebody has stage 4 prostate cancer, you don't want to say too much to them. But at any rate, that was my experience. Okay, number 19, the ovary. The ovary is the female reproductive organ or gland. Then almost all ovaries in nature have an oviduct that carries the eggs somewhere from the ovary. And that's all the way from worms, all the way up through the whole animal kingdom to mammals. But in mammals, something different developed. There is no direct connection between the ovary and the oviduct. By the way, the term oviduct is not used in mammals. It's called a fallopian tube. And I guess the different terminology is because it's not directly connected. And so for eggs to be able to move from the ovary into the fallopian tube, there has to be a mechanism to move them, and it's called fimbria. These are little hair-like cilia that beat and move the eggs from the ovary into the fallopian tube. Sometimes the eggs escape. If the eggs escape and begin to grow somewhere, it's called an ectopic pregnancy. Or if the egg even implants in the fallopian tube, it's called an ectopic pregnancy. Ectopic means out of place. We used the term ectopic when we were talking about PVCs in the heart. We talked about that. Those cells that were doing their best to become the pacemaker cells, they were out of place, and so we call that an ectopic focus. So that terminology, ectopic is out of place. So an ectopic pregnancy is just an out of place pregnancy. There are these sets of ducts called Mullerian ducts. Remember this, these are embryological tubes that become the female reproductive system that we'll deal with in the concepts a little bit later. There are diseases associated with the female reproductive system also, just like in the male. But the one that's the most common is cervical cancer, that is cancer of these cells right here at the opening in the cervix itself, in the opening in the uterus. And this type of cancer has shown a correlation between HPV infections. HPV is a human papillomavirus, and there are about, there's like 30 different species of it. But there are 4 of them that are instrumental in causing cervical cancer. But there is a very simple and not painful test, I'm saying this from a male point of view, called the pap smear, that identifies abnormal cells in the cervix, so that cervical cancer should be a thing of the past. It is not, because there are many people that will not have pap smears, just like a lot of men that will not have a prostate test, a prostate exam. And so cervical cancer, which is a very slow growing cancer and one that's fairly easy to handle, at least in the beginning, still bothers people today. There's another disease called pelvic inflammatory disease that is an STD, usually caused by chlamydia, that can cause infertility. There is another condition called endometriosis. We're going to talk about this lining of the uterus in a concept. This is the endometrium. It's a epithelium, and we'll talk about how it's based just like this epithelium of the skin, pretty much. But this epithelial tissue begins to grow on surfaces outside of the uterus. And this is a very painful condition. Usually it's hormone induced. It is something that can cause infertility also, but very difficult to handle. And usually the only way to handle it very well is by having a hysterectomy. So growth of uterine epithelial tissue on the outside of the uterus itself.
Can you say that one more time? That was pretty fast.
Endometriosis is growth of the epithelial lining of the uterus outside of the uterus on other organs, on other, like sometimes it grows on the ligaments. It can just, it's sort of like just gets everywhere. They have done surgery before and used lasers to try to kill that tissue. But it doesn't seem, if you've got a real bad case of it, it doesn't seem like that it stays. You kill the cells off, but they seem to grow back. And here I'm speaking about something that I don't know much about. I had a student, I think it was last semester, maybe semester before last, that after we had this discussion in class, she stayed back late and said, I have endometriosis and I'm just hurting really badly, but I want to have one more child. She was a young woman. She had one child and she was trying to put off having a hysterectomy until she had one more child. She wanted 2 children. And she was in tears, basically, because she just hurt so bad. But she wanted that child so badly. And I would love to know what has happened over the time, because she was trying to get pregnant at that particular time. Sometimes you get to be a sounding board when you teach these classes. But she needed to talk to somebody. Too bad she didn't have somebody, a better listener, or at least a more informed listener, because I really didn't have much to add to the conversation. All right. That get it? Okay. help me out here. I think we start with G, right? Concept G. Okay, so kidney shape and location. Way back up here where the kidney is. Kidney shape, I don't know, you think about kidney beans? That's pretty much the shape of a kidney. Bean shaped. Location is, it's in the upper lumbar area. Notice here it's under these false ribs. I had to have kidney surgery. I had a tumor right here on the lower part of this kidney 3 years ago now. It was stage 1. It hadn't spread anywhere. But the surgeon told me, he said, thank goodness you weren't too much overweight, because if you had been, we would have had to take this rib off, take this rib out of the way to do surgery. And I'm not sure if they'd put it back, just break it and put it back, or if they would take it out. I don't know. I don't think a whole lot of things attached to this rib, at least not in part of muscles. But we need to go down to this diagram. And look at this view of the kidney. Now this is looking down in a transverse section. So you're looking at about that L2 or 3 level. And you see this is the abdominal cavity. The peritoneal lining that covers the abdominal cavity is here. And so your other organs would be in this cavity right here. And now here your kidneys back here, behind this peritoneal layer. Okay, so see that term in parentheses on concept G? Retroperitoneal. Kidneys are located in their own little compartment behind the peritoneal lining. This is where all the other organs are. This is where the kidneys are. So they are located in a special compartment. When we look at the layers of the kidney, what I would like to do is just trace the passageway of urine from the inside of the kidney to the outside. So if we, oh, come on. So if we look at this diagram and remember that the nephron was the beginning stage of the kidney. So urine begins right here. So the nephron is the first step in concept H, where we're talking about the pathway for urine throughout all the layers of the kidney. So the nephron is the first step. The nephrons empty into the collecting duct. So the collecting duct is the second step for the passageway of urine. Now, the nephrons are here in this section of the kidney. So the collecting ducts are all going to go and drain down into these little passageways. Remember what these were called? This word, calyx. So from the collecting ducts, the urine goes into the calyx. The calyx all wind up at the pelvis. The pelvis drains through the ureter. The ureter drains into the bladder. The bladder drains by way of the urethra to the outside. So that's the pathway of urine, starting with the nephron and going all the way through the urinary system.
Mr.
Professor
Moore,
Moore,
Go. Go ahead, Salima.
after the urethra, it was the bladder?
No, wait a minute. Urethra is emptying the bladder. Ureter, U-R-E-T-E-R, is the tube going to the bladder.
It's the ureter, then the urethra, and then the bladder.
No, ureter, bladder, then urethra.
Okay, thank you.
Jordan?
That was kind of my question. Pelvis drains through the ureter, and then what?
Into the
Like, what's in
bladder.
between the bladder draining? The ureter just connects to the bladder? Okay.
Then the bladder drains through the urethra. Everybody okay? On concept I don't really care whether you do this or not. This is just a stick figure kind of look at a nephron. Don't worry about what's written all over it. This is a diagram that we're going to use later. We could think about this picture, but this has got too many convolutions in it. And so if we just look at the nephron from this point of view, and all I'm going to do is transfer those functions from the vocabulary into this picture. So if you want to, I mean, it's up to you whether you do it or not. If you want to make a little sketch like this, it doesn't have to be, just make your little circle, put your down drop, go down deeper, and then this part, and running into a collecting duct. What I just want to do is outline what happens in all of these different areas. So if you want a sketch, I'll give you time to do it. We're going to emphasize this test cycle and then really look at it in detail next test cycle. But in this little component now, this was the Bowman's capsule. This was where filtration occurred. Now, filtration, of course, I mean, just in discussion, filtration is taking the fluid out of the blood and putting it into this urinary system. Now, filtration occurs here in this first area right here. This is where you have the reabsorption of fluids. The predominant thing is reabsorption of fluids. This is the loop of Henle. Just don't worry about putting anything in about what goes on here yet, because we'll deal with that the next test cycle. But over here, we have the reabsorption of the electrolytes, or I've got ions here, but it's sodium, potassium, calcium, those kinds of things. And then the collecting duct was creating that final concentration of urine. What it does, it controls urine output.
You said that's called the what?
The collecting duct. The collecting duct controls the fluid output. Now, this is directly connected to vocabulary word 13. That's where this information is if you want to make a note there. And I use this real simple sketch just because this has way too much convolutions in it. Okay, so filtration, reabsorption of fluid, reabsorption of electrolyte, final concentration of urine. Okay, concept J. Now let's talk about these three layers of the lining of the uterus. The outside layer, tough connective tissue layer, again, I've said this every time we talk about the outside of any of our organs. This is called the perimetrium. Metrium is the term for this tissue. Peri means around. So this is the perimetrium, the lining around the uterus. The muscle area is the myometrium. Remember, this is smooth muscle. Its major role is to propel the baby out during birth, but it also is the part that gives you cramps during your cycles. Then the internal lining is endometrium. The endometrium is an epithelium. Now let's think back to what epithelium means from AP1. Remember, you have a basement membrane and you have cells binding to it, right? This is what you're talking about, that an epithelium is. Now, this epithelium is similar to like the epidermis of your skin. If you'll remember, we had a stratum basale in your epidermis that produced cells, they were stem cells. Well, here, there is a layer called the basal layer. So the endometrium, that lining of the uterus, internal lining, has a basal layer. It's basically that stratum basale kind of layer that was in the epidermis. It's very similar because it's going to produce cells. The cells that it produces make up what's known as the functional layer. So it's an outside layer of cells on the outer edge of the basal layer. The basal layer would be stem cells. The functional layer is the place where the embryo would implant, and that's where it would develop the tissues that support the growth of the baby, the placenta. What if there is no embryo? Then these tissues break down. That's where the bleeding occurs during the period. And this basal layer, then we will rebuild the functional layer a few days later. So this is the sequence behind the period, the bleeding, and then the redevelopment of that tissue later for the next cycle. All of this under hormonal control. All right, last concept. Don't really have any scenes for this, so we'll just leave it right there. Sexual maturation. external genitalia, and the internal organ systems. So I put this in a chart so that you would not have to worry about trying to develop it. You need to just sort of keep up with what's going on and put notes on it if you feel like you need to. To sort of introduce this, want to look where it says in bold, bipotential gonadal tissue. Bipotential. In other words, tissue that can be developed either into a male or a female system. So it's gonadal tissue that can develop into either gender. They're the Wolffian ducts and Mullerian ducts. That's the bipotential gonadal tissue. They're both embryological tissues. One is going to be developed and one is going to be allowed to decay. Now we have another kind of tissue called genital tissue, homologous genital tissue. The point being, I want you to understand that the reproductive system is not the same tissue set as the genitalia. Does that make sense to you? See, the ovaries, the testes, those are reproductive systems. Genitalia is tissue that's made completely separate from the reproductive systems. They're supposed to match, but they're not the same tissues. So they don't develop together. This will explain a lot of things to you. All right, so let's look first at the bipotential gonadal tissue, the stuff that's going to make the reproductive system. Remember that it's embryological different tissue. Okay, so everybody remember what an SRY gene is? I think we talked about this in AP1. SRY is the gene on the Y chromosome, and SRY stands for sex region of the Y chromosome. Guys, the Y chromosome is basically nothing but SRY genes. There's nothing much on the Y chromosome except human male genes, the SRY gene. Okay, so if someone has a Y chromosome, that SRY gene is present. The SRY gene is going to cause the development of some secretions, some basically you call them androgens if you wanted to. They're male hormone type materials. And they come before the testicles are actually developed. So they're in the fetus quite early. And one of them is called testis determining factor. Well, what does that do? The testis determining factor causes the secretion of anti-Mullerian hormone. All right, what would that do? What would anti-Mullerian hormone do? What is the purpose of the Mullerian ducts? That's to make the female system. So this secretion, TDF, inhibits the female reproductive system from growing. So it basically cancels it out. So if you have a Y chromosome, you can have a female reproductive system. And you don't. What else does it do? It causes the production of testosterone. Well, what does testosterone do? Testosterone causes the Wolffian duct to develop. What do Wolffian ducts develop? We're going to say they're going to become the male reproductive system. So listed below is what they make. Let me get up to the male reproductive system a minute, to this part. Okay, so what do secretions do, or what does testosterone do from Wolffian ducts? It creates the vas deferens, this tube. It creates the epididymis, which is this tissue here, and it causes the migration of these testes down the inguinal canal to drop into the scrotum. So you see that makes the male reproductive system, but we don't have any genitals yet. The genitals develop from this homologous genital tissue, and DHT, which is a form of testosterone, causes the male genitalia to develop into a penis. So if you go left, if you have an SRY gene, you should get a male baby. Let's go right. This was put on the right on purpose. So this is the right way to go. If there is no Y chromosome, there should be no SRY gene. There should be no TDF, which means that the Mullerian ducts are going to develop. The Mullerian ducts will make the fallopian tube, the uterus, and the vagina. Those Wolffian ducts that would have made the male system degenerate. And now the fact that there's no testosterone, that homologous genital tissue does its normal thing and develops into the female clitoris. So there is your development of your different reproductive systems and the different genitalia. The reproductive systems don't usually fail. What can fail is the homologous genital tissue developing properly. So sometimes the receptors for testosterone, looking at the left side, the receptors for testosterone do not receive the hormone correctly, and that homologous genital tissue is not stimulated to change into a penis. It may be partially developed or maybe not developed at all. This leads to a XY female. An XY female would have male reproductive organs internally. Those testes never descended, but might have almost a vagina or at least partially developed. But they still have the male reproductive system inside. These are the ones that undergo sex change operations. Because if you have not been under the influence of testosterone, your appearance is female, it's feminine. And so the male reproductive system is removed internally. There may be some modification done to the vaginal area, removal of perhaps that stunted penis, and maybe the development of a partial vagina, or maybe even a full vagina. But this is called AIS, androgen insensitive syndrome. You can look up AIS sometimes and see the development of these that used to be males, but they are female now. This is the actual beginning of what were called sex change operations. this was not normal people having sex changes. This was people that have abnormal development of the genitals. But see, they're not going to be able to reproduce because they don't have the female reproductive system. If you're an XY female, you will not have a female reproductive system. You may have a vagina, a partial at least, but they will not be able to have children because they do not have the female reproductive system. So just some things for you to look at, some things to investigate. You feel like you know the normal way. I'm not going to ask you the abnormal, but the normal way is SRY gene creates signal molecules that create the male. If there's no SRY gene, everything is pretty much default and it goes the other way. And that's why I say that's the normal thing. See, women are normal. Men have to be changed. Men have to be produced. Anybody can make a female. You think you can describe that system in an essay? We'll see. Okay. Talk to me. Anything else?
Can we go back over number 16 again? I missed the liquid cells. That's difference.
The first type of cell was a Leydig cell. Leydig cells produce the androgens. Those are the male hormones. Then the seminiferous tubules produce the sperm. They got it? Okay, good. We're going to hit the male and female reproductive system a lot in the lab. There's a lot of other good pictures on it that I didn't include in the lecture. In the lab, there's some interesting concepts about how the blood, the oxygen leaves mother's blood and gets into the fetal circulation system. It's a pretty neat little system.
Oh, I had one. Prostate gland, donut-shaped gland that surrounds what?
Urethra.
Thank you.
It grows, it grows and it sort of closes up its donut hole as it begins to get more cells over time. That's what squeezes down on the urethra. Any more good things to cover? Y'all look up Jamie Lee Curtis sometimes. She's always the one that's being accused of being an XY female.
Are we good to go, Mr. Moore?
Oh,
What was that?
I hope so.
Okay, sorry, my child is screaming like a banshee, so I apologize.
Be gentle to her. Him, be gentle to him.
He needs to be gentle to me. He's a biter. He bit me 3 times before class. Thank you. You have a good night.
See ya.
Professor Moore,
Talk to me.
for your AMP2 class, is it all the same Zoom ID?